What we said was, from the other time, we divided this segment into 4. First, the anterior aspect, and then the inferior aspect, the lateral aspect, and then the medial aspect,
which is the septum.
Yes. Always the medial part is the septum. So you won't find anyone saying the medial part. It won't be there. Right. The 4 aspects, lateral, medial, but the medial side is always the septum. The inferior aspect, same as posterior, and then the anterior aspect. We said this is how it will appear in the short axis. Short axis at different levels of the heart. First, at the basal level, base, at the base, yes. This is mitral valve.
This is the area but I brought food with soda.
Fish mouth appearance. Next is at the level of papillary muscle.
That is the mid.
And then at the level of apex. All these ones we divide into anterior, inferior, medial, and lateral. Same here, anterior, inferior, lateral, mid. Same here, anterior, lateral, inferior, and mid. We divide like that. Now, to get the 17 segment, we have to subdivide into more. We are subdividing the medial side and the lateral side. The medial side, it has the anterior aspect of the medial side and the inferior aspect of the medial side. Same happens to the lateral. It has the anterior aspect of the lateral side and the inferior aspect of the lateral side. All those divisions, it depends on coronary artery distribution. That's why we need to divide them into the 17 segments, because to demarcate which area is supplied by which coronary artery, so that when you're doing echo and you see wall motion abnormality, you report it. For example, base, the medial part, the basal part of the anterior wall is not moving. Hypokinetic, the anterior wall is hypokinetic at the base. So we have described the anterior wall. Which part is hypokinetic? The base, meaning the rest, they are moving well. Or the inferior wall is hypokinetic at mid. Maybe the middle part, the basal and the middle part of the inferior wall are hypokinetic. Like that.
Yeah.
So that's how we describe. And then this one was a refined drawing of this, and we had to label everything. Like anterior remained as anterior.
Inferior remained as inferior.
Remained as inferior.
It is the septum and lateral which are subdivided into anterior. Now this is at the base. At the level of the base.
Yes. Basal, anterior septum.
Basal, inferior septum.
Yes.
Basal,
inferior.
Septum.
Inferior.
So inferior.
Basal, inferolateral.
Then basal anterior.
Yes. Basal anterolateral and then basal anterior. We give them numbers.
1 to 6.
Anterior, yes, 1 to 6. 1, that is anterior, basal anterior. 2, basal anterior septum. 3, basal inferior septum. 4, basal inferior. 5, basal inferolateral. And then 6, basal anterolateral. We give them. We went back to mid and we did the same here. From 6 we go to 7. That is mid
anterior. Then
mid anterior septum.
Yes.
Mid inferior septum.
Then mid inferior.
mid inferolateral, and then mid anterolateral.
Yes.
Uh-huh.
This is towards the posterior. This is the posterior wall, I think.
Yes, this is a posterior wall. Inferior is posterior. So when you don't say inferior, you can say posterior because you have anterior. Anterior, posterior. So they are the same. We went to the apical part. We said there we are not going to subdivide anything. We're just going to let them be lateral, medial, inferior, and then anterior. But this time it is towards the apex. So,
apical anterior?
Yes, we have apical anterior.
Apical septum?
The apical septum.
Apical inferior or posterior?
Yes, apical inferior or inferior apex, and then the lateral apex or apical lateral. The 17th one was the apex, the real apex. So this one mid anterior, it was 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Then the 17th one
is the extreme.
Is the real apex. Yeah. So this is what we covered yesterday.
Assuming this is the heart, this is the 17.
Yes. So if you have to first go for lunch, you can go, we come back.
Yeah, let's go. That is it. What's there?
Now, from short axis, we went to other views, and we see which walls of left ventricle do we see. Again, remember I told you we don't focus on right ventricle because it's not all that important. This applies to only LV. Maybe in some special conditions when it can act on RV, but not much. So we name this one as a Plaques view, where we see the aortic valve and the aorta, left atrium, and then the mitral valve. Mitral valve is the same as mitral inflow. This is inflow. Mitral valve, left ventricular cavity, RV, and then interventricular septum, and then the normally we hear people calling it posterior wall, but this is posterolateral wall. And this is the base. If you put this cut, this section at the mitral valve level tips, it is able to be the base. At the level of papillary muscle, you cut, it will be the mid. And in this, we are not seeing the apex. That's why I will not join this side. Even on echo, the good Plaques view, you shouldn't see the apex. So these are the walls we are seeing. We are seeing anterior septum,
yes,
and the posterior lateral or inferolateral wall. At the base and mid. The apex, no. Now another view is it apical. The apical views using the apical window. At the apex chest, if you get the cardiac impulse, when you touch, you will feel the heart visibility. So that point there, at the apical impulse, you put the transducer. When the probe marker is pointing to the left side, and then you tilt a bit, you will see, you get the apical 1. What we are starting with is the apical 4 chamber. We start with the apical 4 chamber. And the apical 4 chamber, the 4 chamber, the heart, normally it is 4 chambers. So meaning the 4 chambers are talking about 2 atria and 2 ventricles. And then from the orientation, we are having
so this time the apex has to be here, close to the probe.
is
We respect the left ventricle, the thickness.
yes, you have to. So this is the fourth chamber as RI, LA, LV, RV, mitral valve, tricuspid valve. This is the apical fourth chamber.
So here we are not going to appreciate the aortic valve.
No, we are not going to see it. So, if it's like this, if we go to our wall labeling, this one is going to be the lateral side, left ventricle. Right ventricle is in the medial side, and the left ventricle is on the lateral side. So this is the lateral side. Right ventricle is on the medial side. This is on the lateral side. So this is going to be the lateral side. So one, we know this is lateral, and another one we know that this is medial. But we said what is in the medial?
Septum.
Septum, yes. So meaning this one is
medial stroke septum.
Now for this we are ignoring the RV here because it's not part of our 17 segment model. It's not part. So we are considering this one. You know, lateral, there is LV, medial, there is septum. So now the next thing is to check which lateral is this and which medial is this. Remember, we divided lateral and medial into different anterolateral
and infra.
Yes, anterolateral. So this one is going to be anterolateral. And if anterolateral is this side, then anterolateral is this side. Or like on our, remember this, anterolateral was here. And meaning if we draw a line, where has it passed? It has passed through anterolateral and inferolateral. You can't draw a line like going like this. No, you want diagonal. Because that is how the beam is sent. The beam is diagonal. So anterolateral, it is passing through inferolateral. So meaning this one is
septum.
Yes, this meaning this one is inferior septum. Anterolateral wall and then inferior septum. So again we can go to either base, mid and apex. So anterolateral, if you cut like this, base. If you cut like this, capillary muscles are here. Now we are going to see them because this is inferior septum, and we said this inferior papillary or medial papillary muscles, posteromedial papillary muscle. So it's on the medial side, it's on the septum. Now we are going to see it. Maybe this one, this papillary muscle, we can also see it in this view. So if you cut a papillary muscle, then this is mid. If you cut away, so we put other names as usual. Base, that is basal, anterolateral. Mid,
anterolateral.
and then apical,
Anterolateral. Apical.
lateral. apical, lateral, or lateral apex. And then if we go this side, what do we have this side? Right.
Epicolateral. Reason that last part of the apex, it was divided just into 4. Anterior, lateral, inferior, and medial.
So we have named these ones. So now I'll name this side.
So this is basal, inferoseptum.
Basal. Yes.
This is basal, inferoseptum.
Basal, inferior septum, or inferior septum.
And then this is mid. This is mid. Infero. Mid inferior septum still.
Yes, it is still inferior septum.
And then this is apical. This is apical septum.
Nice, good. Yes, that's how it is named for chamber. So whenever you see for chamber, we are doing equal, and then you see for chamber. Then that is how it is. So this is how it is. Whenever you see equals being done, and then you see these ones, practice is supposed to be how to name the walls. How to name the walls, how the walls are named. You identify them. This is anterolateral, inferolateral. This is anterior septum, inferoposterior, or inferolateral. And then the next one is going to be the...
Later, this is anterior. This is posterior. Or inferior. So those two things interchanging, posterior and inferior.
You'll get to it. The next one we have seen so far. This one is done. Anterior septum is done. And then inferior septum is done. Anterolateral is done, and this one is done. So what is remaining is connecting anterior and inferior. So we are going to connect anterior and inferior, because that is what, when you are doing it, you have seen that when I'm doing it, I first take the short axis, I first take the other one, ax view, and then I do whatever I'm doing. I take short axis at all these levels. What you have not drawn is at the level of the value, because it's not part of this, say, wall segment analysis. And then from there, you see, I go to four chamber. Now, before I have to do anything on four chamber, I first save it. I save it clean. And then from there, I can apply colors and check regurgitation, do the Doppler of mitral, aortic, and the tricuspid, but after saving the clip. And if that clip is not clear, I have to keep trying until when I get a clear clip of the four chamber. Why? Because I'm seeing contractility. Here, when I'm taking this one, I see contractility at the base. From the cardiac anatomy and function and the mechanics, we know the base is not all that mobile. it moves less because of the annulus. There is a ring there in the anatomy of the heart. There is a ring which separates the atria from ventricles. There is a fibrous ring there. And the muscles, the muscle mass there is not much. So this one is not always moving so fast or so much as compared to from mid to apex. So when I take here short axis, I see how it is contracting. I go to mid, I see how it is contracting circumferential. This is circumference. This is showing circumference, so you can see at different points here, 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 and compare. And then I go to the apex and compare the contractility. And then from there, I go and then take this one now. This one I've already taken it from the start and I've assessed how it is moving. How I know from in plexus view, anterior septum and posterolateral wall, they are moving very well. I go to four-chamber, I still assess. I don't assess this one. If I want to assess this one, I will do something else. It is called TAPSI. And M mode passing here. But for this one, I will only focus on this part. I will focus on this part here to see if it is moving at the same expense inside during contraction. So that's where I will focus more. Is it pulling inside, coming inside at the same expense during contraction? If yes, then I confirm there are no wall motion abnormality. If there is any abnormality, we report it like as wall motion abnormality. Wall, these are walls. Don't use the term myocardium, no. Wall motion abnormality. If, for example, you have seen here it is not moving well, and here it is moving well, but here it is not. So meaning there was wall motion abnormality. But if the movement is the same and equal at all, in all parts, then no wall motion abnormality. Then I will know I've assessed anterior septum, I've assessed posterolateral wall, I've assessed anterolateral wall, I've assessed inferior septum. So what is remaining is the anterior and the inferior. So inferior is going to be the apical two chamber. So from there we draw the two chamber. Two chamber, we are focusing on the left side. Can you draw it? You have been drawing there. We are focusing on the left side, not the right side. And we are talking of two chamber. Which chambers will be those?
The left atrium and left ventricle.
Where the apex should be? The apex, where should it be pointing?
The apex. That?
Like, how would the image orientation? You try to draw it. It is not in the camera. Try to draw it. Just a small thing. So you can guess how it will look like. That is apical four chamber. Now we're talking of apical two chamber. Which are the chambers? We have said left atrium and left ventricle. We are focusing on the left side. How would they look like? Orientation.
Showing this left ventricle. Sorry, left atrium. So flow to the left ventricle. And then maybe I'm having my aorta somewhere here.
We're talking about two chamber.
So that means I'll eliminate this, then I just have this.
We draw that one on the next page. What happened to this side? Name the anatomy. The apex is where? Yes. So, if this is the apical two chamber, yes. Then apical two chamber, you're going to see anterior and inferior. Anterior and inferior. There is no septum.
So I presume this is anterior, this is inferior. This anterior, this is inferior.
I'm talking of the walls. This one cannot be inferior. Anterior, inferior. Remember image orientation and probe marker? We said like where the probe marker points, that is the area, that is the part that appear on the left, on the right of the screen, or on the left of the screen. Where the probe marker points, that part of the body will appear on the left side of the screen. So apical two chamber again, four chamber, as long as it's apical, the probe marker is pointing to the left. So if it is pointing to the left, and we say this side, we have the left ventricle, this side, and we are focusing on left ventricle. But now, how we orient this thing for apical two chamber? The probe marker is pointing to the left, but not all that to the left. You have to rotate it a bit, some bit of rotation and tilting, so that you send images. If this is the probe marker footprint, that is the footprint, meaning the beam will come out like that, and it's long like that. If you put the probe marker like this, slightly tilted, meaning the beam will just go and cut into two, the left ventricle only. So where it is placed, directly placed,
so the ventricle.
Yes, it's on the anterior wall. It is placed on the anterior wall. So the anterior wall will appear, and the beam will just continue downward to go the heart.
What's the second one?
To the posterior wall it goes.
Patient.
Okay, I'm coming.
Let's come and pick a patient.
I'm going to pick it. So which procedure? I'm coming.
The heart is like this, it is 3D. So if the probe marker is here and the beam is being sent like this, deep inside, this is anterior, this is inferior or posterior. Anterior, posterior. The probe marker, the beam cuts, penetrates and goes down.
That one has sunk in the head.
So this is anterior. Again, what level is that?
That is a base. Apex.
And the real apex now, the 17. We need apical two chamber. We are seeing the real apex. Even in four chamber, real apex is seen, but in two chamber, the real apex is seen. So this is base, mid, and apical. So this is basal anterior, mid anterior,
Apical anterior. Apical.
yes. So name the rest this side.
This is base, inferior, mid, inferior, then apical, inferior,
And then apex.
and then the apex.
Yes. So far we have seen the 17 segment model from short axis and then long axis, and then the apical views. We have seen there's another 3-chamber view. We may not see it, but I'll be showing you when I do it. 3-chamber view, and then the 5-chamber, the 4-chamber, but now we show aortic, but it's not, it's not used to. It is not used to assess wall motion. 5-chamber, not used. So that's why I'm not drawing it. Maybe very fast to combine the short axis views with their numbers. Yeah. We had something like that. We divided into 6. That was anterior septum, inferior septum, inferior, and then here you see 1, 2, 3, 4, 5, and 6. This thing is going to continue because even the second at mid, this is at base. Now this is at mid. It still continued. We still had 6. So meaning 6, 7, 8, 9, 10, 11, 12. Now this one we had
12.
Yes. This one we had only 4. We had only 4. As the anterior, as it 13, 14, 15, 16, and then
the apex
17. This is the bull's eye.
Bull's eye, when I come to abdominal scan, that is appendicitis.
This is the bull's eye. With advanced echo, we shall see this, how it is used to really assess.
You can look at this at once. You can't.
This bull's eye, if you apply it, there's some modality called GLS. What is it? Global longitudinal shortening. We use this bull's eye and with different colors to show that this part is moving, this part is not moving. But for now, you first go and see your patient.
It's 3:30.